Good evening, everyone. Myself, Dr. Raghu, Emergency HOD at Yashoda Malakpet. So this week we have topic will be on golden hour management of shock in children. So as we all know, Yashoda Hospitals in association with Anbai and Semi Board, we are bringing every week one different topic with an expertised speaker for the enrichment of all the students who are joining and for the better expertise. So, as we all know, sepsis in children is a devastating complication. So, it is a global health issue. So, global health observation, this is past, I think, 4 or 5 years back, where they observed 58% of deaths in children under 5 years of age because of this infectious disease. And of late, the mortality has been coming down because of the various immunization programs, and these children have been immunized for pneumococcal and H influenza. So, as all we know, the golden hour first 1 hour will be crucial for all the children. So it starts with the ABC and the fluid resuscitation. So it is none better than Dr. Suresh sir, who is the lead consultant at Yashoda Hospital, Somajiguda, who is in the pediatric critical care and pediatrics. So sir will be taking about for the next 1 hour, the golden hour management of shock till children. Over to you, sir.
Yeah. At the outset, let me thank the ER team and Anbai for giving this opportunity to discuss a topic which is very close to my heart. That is golden hour management of shock in children. So next 30 to 40 minutes we will discuss, and then if there are any questions, queries, we will take queries, that's for sure. Okay, let's start off with a scenario. This is a 5-year-old girl child who has recently traveled from abroad, presented with sudden onset fever and rash over the trunk, which was rapidly progressing. On examination, child was sick looking, child was febrile, and child had mottled skin. And on further examination, there is a maculopapular rash all over the body. Remember this scenario. We will discuss more in detail about this one. And coming to the second scenario, this is a 3-year-old kid, fever of 5 days duration. As in many cases in India, child was self-medicated for 5 days, taking medications from the pharmacist over the counter, and subsequently presented to the emergency room with the fast breathing. And on examination, child was lethargic, and on inquiry, child had reduced urine output. On further examination, this kid was sick looking, had evidence of poor perfusion, and was febrile. Now, what are the commonalities in these two scenarios? Both are children presenting to ER. Now, if we look at the commonalities, both of them are sick looking, both of them are febrile, and possibility of sepsis. Anybody who is working in ER, having a basic idea of pediatrics, would definitely think this as sepsis. And then how do we go about, and why Dr. Raghu was stressing the importance of sepsis? Because if we look at the statistics across the world, sepsis is the topmost killer, be it acquired or hospital-induced. Either of them, sepsis is the topmost killer. And most importantly, every minute without the diagnosis or every minute for delayed diagnosis or delay in initiation of treatment reduces the chances of survival. It might sound very dramatic, but yet if we look at the numbers, we have to agree. Now, for this reason, we thought we will have this very important topic to be discussed in the evening. So let us look at the overview, what all things we are going to see. So we will look at the definitions of sepsis, septic shock, and some old definitions which are outdated now, and how to recognize sepsis, how to recognize shock, and how to recognize septic shock. And what do we do after that? Let us see that. So these are all the latest definitions. Sepsis, as we previously thought, it was something which the bug causes. Whereas now with the evidence of more and more scientific data coming up, now new definitions have come into picture. It is a life-threatening organ dysfunction which is caused by the dysregulated host response. It is not the bug or bacteria which is causing. but it is the body's response which is dysregulated to cause this organ dysfunction is defined as sepsis. Whereas septic shock, it is a subset of sepsis wherein there is some circulatory and cellular or metabolic dysfunction. Previously, we were talking about SIRS, that is Systemic Inflammatory Response Syndrome or severe sepsis. But current surviving sepsis guidelines, we do not talk about SIRS or severe sepsis anymore. Now, how do we recognize sepsis? How do we recognize shock? How do we recognize septic shock? Is there a common way of doing it, or there are various methods? Now, simple ones like screening tools are available and recognition bundles are available, or we can have an institutional pathways. I'm going to talk about each one of them in detail. Now, before we go into the recognition of sepsis by bundles, let us just continue the scenario because we need to do it in a systematic way and clinical judgment plays an important role. Now, the child arrived to our ER, was examined by a junior resident. The PAT, that is initial assessment, shows child is sick looking, increased work of breathing and pale. So there is a life-threatening event that is pale looking. So we have alerted our emergency response system, started the child on 100% oxygen, and we move on to primary assessment, that is ABCDE. Airway seems to be stable with some secretions, and breathing-wise, child is tachypneic. SATs are 92, mild subcostal retractions are there. Circulatory-wise, cap refill time is 3 seconds, heart rate of 148, and blood pressure was not checked by then. Disability-wise, child is responsive to voice, that is V by AVPU, pupils were not checked. And on E, that is exposure, there is rash on lower limbs and febrile with a temperature of 103.8. Now, looking at this, what anybody would see and think and analyze and then come to a conclusion is this child definitely has a respiratory problem, that is respiratory distress. In addition to that, the child has a circulatory dysfunction. Based on the numbers available, possibly child is in compensated shock and febrile. So what do we do next? And why do we need to do it quickly? That is what we are going to see. So anybody who is working in pediatrics, obviously, we are trained to do that in a systematic way. But now let us look at ER way. Because here in emergency room, you come across all age people, be it a child or an adult or an adolescent or a geriatric population. So it becomes very difficult to remember numbers because the moment if I put this assessment triangle and 148 of heart rates, so anybody would panic if we are dealing only with adults. But in pediatrics, we have various age groups and the heart rate varies based on the age. So easiest way is to have some kind of traffic light system to identify a sick child. Now, this is from UK where I worked, from National Institute of Health and Care Excellence. If you look at this, there are 5 parameters which are taken into consideration. That is color, activity, respiratory system, circulation, and others. Based on the numbers or based on the findings, we can classify them into either green, amber, or red. Something similar to our triage system which we use. The ones which fall into the red are at a higher risk, and the ones which are in the green can wait for their turn to come. So if we try to fit in that scenario and the respiratory system, child is tachypneic and retractions are there, but he fits into the amber one. That is respiratory rate of 50 and then saturations are less than 95%. Heart rate is around 148 and cap refill time is prolonged. So we would classify them into amber. But when we look at the other things, that is child has a rash, that might have to alert us thinking because child has recently traveled from abroad, is there a possibility of something like meningococcal septicemia? So now to recognize the shock and then club it into the meningococcemia, we need to recognize the shock much earlier. If we wait for the blood pressure to drop and make a diagnosis of shock, we would miss the bus. So we need to recognize the shock when child is in compensated phase. That is tachycardia, increased cap refill time, and peripheral pulse volume and central pulses. Ideally, we need to check both central and peripheral simultaneously. If central pulses are weak, it is an indicator that possibly child is in hypotensive shock. But central pulses are felt well, but peripheral are weak. He is giving us time because child could be in compensated shock. Again, look at the extremities, cold peripheries. And in compensated shock, ironically, systolic blood pressure can be sometimes high. Whereas in hypotensive shock, child, as the name suggests, blood pressure is less than 5th centile. And we don't have a single number unlike in adults. So what we teach and what we practice is 70 plus 2 times the age. That is a 5-year-old child. If blood pressure is 70 plus 2 times 5, that is 80. We are talking about systolic blood pressure. We consider it as less than 5th centile. And then we consider child is in hypotension. In addition to that, child might have altered sensorium because of poor perfusion to the brain. And as I said earlier, loss of central pulses can be there. So now we have identified the shock. We have looked at the color-coded system. Now, how do we identify sepsis quickly? So if we look at this table, there are 3 or 4 things. Some of them need almost 20 parameters. So instead of that, what we follow, what is being advised to follow in an emergency is the last one, that is QSOFA. There are only 3 parameters: respiratory rate, GCS, and systolic blood pressure. QSOFA is nothing but a quick sequential organ failure assessment. So this gives us an idea if child is septic or not septic. Now, what do we do after that? Though this one I'm going to discuss in detail because this is a small font which is not easy to identify. And when we identify the child to be having sepsis, are there any red flag signs? Here is where we need to act very quickly because time is very precious. So let's start in a systematic way. Step 1, start using this chart if you feel child is not looking well. Very simple. So don't bother about anything else. If your initial assessment, you feel the child is septic, just use this. And could this unwell be because of some infection? If you think yes, then look for source, whether the child has respiratory source focus or focus in the urine, or is there any joint or skin involvement, and then look for red flag signs. There are 7 red flag signs in pediatric. One is altered mentation and systolic blood pressure less than 5th centile, or a drop of 10% systolic blood pressure from the previous, or tachycardia, or a rise of heart rate 10 over the baseline, or need for oxygen to maintain a normal saturation, and then if there is any non-blanching rash. If any of them are there, they are the red flag signs, and go for bundles. What is this bundle? One of the classic example of care bundle, like how if we have a child on ventilator, we use VAP bundle. If we have a child with central line, we use CLAPSI or central line bundle. Similarly, we have sepsis bundle. It obviously does not replace PALS or ACLS guidelines. But again, this is an extension of what we do in PALS. This helps in early recognition of sepsis and very early initiation of therapy. So classic 6 steps, that is pediatric sepsis 6. So step 1, if you think child is in sepsis or septic shock, things which needs to be done in 1 hour. That is what we were talking about, the golden hour. So if you think this child to have sepsis or septic shock or any of the red flag signs of the sepsis which were shown in the previous slide, start using this. So first and foremost, try and inform one of the senior or a consultant, and then start applying these steps. Step 1, start high flow oxygen. When we say high flow oxygen in pediatrics, it's always by non-rebreathing mask with a flow set at 10 to 15 liters. If child is breathing and we connect this NRM, it delivers FiO2 of between 90 to 95. And next and most important step after oxygen is try and secure IV access. In 3 attempts, if we do not get IV access, do not waste time, go for an IO access. Now, most units, I presume we have iogun, at least in Yashoda, we have iogun in all the units, and all are trained to use intraosseous. If iogun is not there, we can use a bone marrow aspiration needle or a blood transfusion set needle, or a thick LP needle also can be used. And when we are putting a IV or IO, take blood cultures, check sugar, and then get a blood gas. One practical point, if you are taking samples from IO, alert the lab, because most labs have automated filters which can get stuck. The particles or bone spicules can block the filter machine. So alert them so that they will do manually whatever can be done. And if you identify hypoglycemia, just treat it. So in pediatrics, we use 25% dextrose or 50% dextrose. In neonates, we use 10% dextrose bolus. And the third step is giving first dose of IV antibiotic. Which antibiotic to be given? A broad spectrum antibiotic. If we have a hospital policy, infection policy, we can use that. Or based on the area where we practice, we can use a broad spectrum antibiotics. And next comes the fancy one, fluid resuscitation. So what do we give? What do we give? What we need to give? How fast to give? What not to be given? We'll discuss in subsequent slides. And sixth one is considering very early inotropic support. We are going to talk about inotropes, when to give, when not to give, and some 10 commandments about inotropes. This is what we used to use in Great Ormond Street. This is a very simple one, easily available, not a copyrighted one. You can use for children in any of the units. Now, coming to the fluids. When to give fluids, how much to give, and how fast to give. Things to be done in within 1 hour are mentioned in at the bottom. If you see 1 to 6, we already saw that we need to get an IV and then collect blood culture, start an antibiotic, and then if possible, which is possible in most units now, measure lactate. Based on lactate, we are going to take some more steps, and early inotropic support, as I mentioned here. Now, these things we will go in detail. Yeah, right. So, which fluid to give? We'll start off with that one. So, maximum of 3 attempts for peripheral IV access. If you do not get it, don't waste time. And intraosseous, like I said, there are various types. And sites, we can choose the easiest one away from the site of resuscitation. That is, if the child requires CPR or back mask ventilation or intubation or something like that, it is safe to be away from that head end. So best one is to choose the lower extremities, 1 inch below the tibial tuberosity. You can use that site. It is the easiest one. There is a flat surface, but again, there are some contraindications. If there is a fracture of that limb and a relative contraindication, one of the relative contraindication is infection at the local sites. If there is access to point of care ultrasound, always use an ultrasound even to get a peripheral vein. It saves time and increases the accuracy. This is the IO gun which I was talking about. And there are some alternatives which I have displayed there. And IO gun is pretty easy to use. Now coming back to the fluid. So depending on the facility where we are working, whether you are working in a peripheral setup where you do not have ICU, or you are working in a facility where you have ICU. So now, if you are working in a facility where you have tertiary care ICU, you can start off with 20 ml per kg of fluid bolus. Previously, we were talking about normal saline as the fluid of choice, but we have realized that with normal saline, we are also causing hyperchloremia. So we are moving away from saline and started using plasmalite as initial resuscitation fluid, because hyperchloremia can cause metabolic acidosis, which in itself is an independent risk factor for increased inotropic requirement and also can cause renal failure. So we started using plasmalite, which has got lower chloride, yet it is a balanced solution. And you can go a maximum of up to 60 ml per kg within an hour. So if you're working in a facility where there is no ICU and child also does not have hypotension, then there is no need for fluid bolus at all. You can just use maintenance fluid. If you are working in a facility where there is no ICU, but child is hypotensive, that is systolic blood pressure is less than 5th centile. Here, we can give a 20 ml per kg bolus, and you can repeat the bolus maximum of 40 ml per kg and continue with maintenance fluid. Now, this again we have said, there is everlasting debate which will never end, crystalloids versus colloids. In pediatric, there are specific indications for colloids, very, very few indications. So let us not worry too much about those exceptions. Rather, the rule is crystalloids, and previously, like I said, NS, and then now we are talking about plasmaloids. Right. Now, stabilization. So we have initial resuscitation and then optimization and then stabilization. So implement systematic screening based on the hospital policy. And if there is a facility to check lactate, obviously check for lactate, and try and give first dose of antibiotic in the ER itself. Let us not waste the time till the child is shifted to the ICU, because most units will take some time to shift, and all these things can delay in initiation of antimicrobial. And like I said, use empirical antibiotic and try and use the broad spectrum one with a maximum dose, no problem. Just a minute, I think a couple of slides are missing. If I can just change one moment. Apologies, one slide seems to be missing in that, so just change. Sorry, that slide is missing, but I'll just talk about that. That is use of inotropes. There are 10 commandments of inotropes which I talk about. Previously, we were talking about dopamine as the first line of using. So now what we suggest is start off using adrenaline very early, and inotropes can be given through a peripheral line, including adrenaline. Anything can be given through a peripheral line. So do not wait for a central line placement for inotropes. And second one is first fill the tank before using inotropes. That is, use point of care ultrasound and check the IVC status. And if you think IVC is collapsible, give some more fluids. Keep watching for fluid overload. If there is no fluid overload and you have chance to give some more fluids, go ahead. If there is any evidence of fluid overload, that is heart rate increased 10 over and above the baseline which you have checked, so start inotropes. That is the second one. And the third one is, if you have to choose a second inotrope, choose something which has a different mechanism of action rather than something which is same mechanism. And fourth one is look for side effects of inotropes as well, because if you have a child in hypotension and you need a vasodilator, do not use milrinone because it causes more hypotension. And you can use drugs, something like calcium channel sensitizers like levosimendan, which is easily available nowadays. And there is no contraindication for starting off early feeds, because now we advocate early feeding after initial stabilization, but that can be taken care once we shift the child to ICU. Okay. And sometimes inotropes themselves can cause fluid retention. So be careful about that. And things what we need to see with technology is looking at the splanchnic circulation, using focus very early. Easy things like IVC collapsibility, 4-chamber view, cardiac contractility. These are the things which should be checked. And if you have a facility and you can just get a quick IJV line, You can even check mixed venous saturation, because that gives us an indication if child is still in shock or not. And very, very important things for ER physicians, because we are always in an emergency, and rightly so, because you don't have just one kid. You might be having some more adults which need to be seen and addressed to. We tend to forget documentation. So most physicians complain that they don't have time to write sufficient records, be it ER physician or a pediatrician who comes to ER. That's a common complaint we see. But now remember this next statement. Would you rather spend the time in court for 3 to 6 months, maybe few years after you forget the case, 5 days a week, rather than few minutes? So which one would we choose? Rather spend little time and document, because palest ink is better than strongest memory. We might think that we will remember this case for longer, but over a period of time, the memory fades away. So always document. And whatever you tell, whatever you communicate, please document. And whatever is documented, please communicate. Both needs to be done. In emergency, a simpler way, what I follow, something called SOAP, extended SOAP. That is subjective, what the parents felt or what I felt after initiation of therapy, treatment. And objective, that is the numbers which I have seen, that is change in heart rate, change in blood pressure, or clearance time for the lactates. And opinions taken, if there is an opinion from a cardiologist or a pulmonologist within the ER, and what are the options available, and what was the advice and agreed plan amongst all the physicians. This need to be documented. And all the sequence of events, including the history and interventions done, and change in the clinical status during the stay in ER needs to be documented, including the timing of intervention. Because in the court of law, what we say might not work, but what we document, a piece of paper, works. And always counsel the parents regarding the clinical status, interventions, investigations, and possible outcomes. And if required, the transport options, because we might be working in a setup where we do not have tertiary care ICU and child might require. But again, remember, we need to stabilize and then only we need to transport the child. So when we are shifting, please make sure that we are communicating with the PICU team. Obviously, in our setup, the PICU team comes down, but sometimes you might be working in a setup where you are the only team available. So make sure the doctor-to-doctor communication, nurse-to-nurse communication happens. And I'm happy to take any questions if there are any. Before I do that, take-home messages. If you are looking from a very close point of view, it's very easy to get distracted. So I see what mind knows. So keep yourself updated with the updated guidelines, even related to pediatrics, because if it is there, even in the back of mind, subconscious level, it comes out. And all that glitters is not gold. At least sometimes we see the heart rate comes down, down, down. So we are excited that the child's shock is being resolved. If it is going at a very faster rate or it goes and comes up, it might still look better than the initial number. But again, remember, that might be the first sign of fluid overload. And a stitching time saves 9. If we do a timely intervention, we might end up saving life, and then we might end up requiring lesser number of interventions. Again, when in doubt, if the child is not responding as you would want, take a step back and then look at it. Something what I call super specialty syndrome. If you are looking very close by only looking at the lung, you might think it is a pulmonary pathology. And if you are looking only at the heart, you might think it is a cardiac pathology. We as general physicians, we who see everything, whole body, take a step back and you might get a clearer picture. If you look at this elephant, you're looking only from the tail end, you might see and think that is a rope. But when you step back and see, you might see the bigger picture of it being elephant. Thank you, and I am happy to take any questions if there are any.
Suresh, thank you, sir. Thanks for accepting our invitation. Thank you so much.
Thank you.
And now to Raghu, sir.
Hello.
Yes, sir.
Yes, Suresh, sir. So as we do most of the adult resuscitation, sir. So when it comes to the pediatric, most of the times the pediatric comes and take over, or there sometimes there may not be so much exposure of the pediatric cases, unless until it is a pure pediatric hospital or for example, like the Child Trust Hospital or the other hospitals. So what is the difference between the adult resuscitation and the pediatric resuscitation? So,
yes, sir.
Yeah. Do we follow the same, like the 1 hour bundle, everything, or is this any difference between the adult and the pediatric resuscitation?
Let me split this question into two parts.
Yes, sir.
See, I'll just put my experience in Yashoda Somajiguda. We have a full-fledged ER team. We have a full-fledged pediatric team. For instance, we had a few weeks ago, there was a very sick child who was brought to ER at 4 a.m. At the same time, there was a resuscitation happening upstairs in the PICU. So obviously, one consultant and one registrar who was on duty would continue to resuscitate that. And the only person who is left to resuscitate in ER is ERT. So let us not differentiate that a setup where pediatrician is there, they will definitely come. Any one of us might be required to resuscitate a child. So that is one. And coming to the second point, are there any differences or changes as compared to adult resuscitation? Current guidelines we talk about based on the place where we are working and the type of fluid which we use and the rate at which we use are different, sir. In adults, to the best of my knowledge, we still use crystalloids, NS or ringer lactate as initial resuscitation fluid. Whereas in pediatrics, we are moving away from that towards plasmolite. That is a balanced buffered solution. And we have very few indications for colloid, unlike adults, like definitive history of trauma, head injury, where we need to give fluids, where we are worried about a lot of other things. We tend to use colloid, but again, we don't use 20% albumin. We use 4.5% human albumin solution. And the rate at which we give over 20 minutes. And in adults, what you tend to do is that you run fluid at a much faster rate as compared to what we give. The volumes might look much higher when you compare with adults. For example, you might ask the nurse to run 500 ml, one bottle of NS quickly. But for us, it's always based on weight. Some slides, for some reason, I missed out. So I'll just tell. So we have weight-based tapes, which we tend to use because practically not possible to remember everything based on the weight. So if you ask Kiran Varma, Dr. Kiran Varma, he might be able to provide to the other units we have. So we have weight-based tapes like Broslo tape. We have a Pedia tape, which is Indian version, something similar to Broslo tape. We just put it next to the child and we get all the dosages. And the other thing is the drugs used are very, very few for us, sir. We don't use atropine during resuscitation. But if you are asking only related to the shock, most of them are similar. Drugs used like fluids, oxygen, getting IV access, broad spectrum antibiotic, there is no change. And the bundle which I showed you is meant for pediatrics as well as adults as well. Those 6 steps remain same, whether it is a child or a geriatric patient. And then drugs which we use, we don't use bicarbonate as much as adults use. And if you are doing CPR, again, we don't use atropine early. We tend to use adrenaline. And if child is not responding, only then we tend to use atropine. I hope I answered your question, Dr. Raghu.
Are there any newer guidelines in your part, sir, now?
Yeah, surviving sepsis guidelines, the new ones are the ones which I discussed. That is where we talk about in a facility with ICU setup and without ICU setup. Those are the new ones. And then measuring lactate is a new guideline, which is very old for adults. So now we are advocating the use of lactate. And if facilities are available, we are talking about use of mixed venous saturation as well.
So we'll see any questions from the audience. So we have a question from the audience. Where can we find antibiotic emergency drug dosages?
A simple book called Harriet Lane. So what I can do is I will share with Dr. Kiran Varma, a soft copy of which can be shared amongst the ER physicians. That's number one. And number two, as of now, we don't have an emergency tape, which I'm talking about as a soft copy. And the third one is we have designed a ready recorder in emergency, which all people working in ER should carry in their pocket. It is a very small one, as much as this. When you open, you have all the dosages which are to be used in emergency. That can be shared with the people from any institution. Not an issue, sir.
What is the role of soda bicarb during shock in pediatric group?
There are very few indications for sodium bicarbonate. Like I said earlier, we don't use much. If child is not in DKA, let us start with this step. If child is not in DKA and pH less than 7.1, yes, you can use. Previously, we were talking about early bicarbonate because there was a theory that if child is acidotic, which can cause myocardial dysfunction. So now there are enough studies in pediatrics which show that inotropes do work even in acidotic state. So if pH is less than 7.1, yes, we can use 0.3 into weight into deficit. This is the formula which we use for emergency. When you are using sodium bicarbonate, please keep a close watch on sodium because hypernatremia and hyperchloremia both are equally dangerous. So when you are using normal saline, keep a close watch on chloride. When you are using sodium bicarbonate, please keep a close watch on sodium. And the name of the book is Harriet Lane. Harriet Lane. We can get a soft copy pretty easily. The other one is BNF. So BNF, every year it changes. I can share both new editions with Dr. Kiran Varma. If the child is in DKA, kindly do not use sodium bicarbonate unless pH is less than 6.9. With adequate fluids and then with adequate early resuscitation and insulin administration, most of the time the pH comes up. So very little role for sodium bicarb because we still feel that it can cause paradoxic acidosis in the brain.
So the drug of choice for starting vasopressor, what is the drug you start? Because we heard
yes,
initially when we were in there, some people used to start dopamine initial and some start used adrenaline. But in the adults, we start usually noradrenaline. Then we add-on therapy will be the vasopressin. If needed, we go in the adrenaline group.
Yeah, unfortunately, those slides on vasoactive agents were missing. Sorry. But I'll answer this question. So previously we were also using dopamine as a first line. But if child is in septic shock with wide pulse pressure, why I'm saying pulse pressure? Previously we were talking about cold phase and warm phase. Now both cold phase and warm phase terminologies have been removed from pediatric septic shock. If there is wide pulse pressure, easy way to remember is if pulse pressure is at least 50% of the systolic. Easy way to remember that. That is a rule of thumb. That is normal. If it is anything more than that, it is a wide pulse pressure. Wide pulse pressure, we start off with noradrenaline. Wide pulse pressure with hypotension, we add adrenaline. Despite adding adrenaline, if child is not maintaining blood pressure, we add vasopressin. But again, try and use something different mechanism of action. If we want something like a vasodilation and inotrope, we use milrinone. If child is still not responding and child is normotensive, we can add calcium channel sensitizer like levosimendan. If child is hypotensive and we need a dilator, we use something like dobutamine. The role for dopamine has decreased over last 2 decades.
And as mentioned, the previous sepsis guidelines is to start the empirical of piperacillin tazobactam as a gram negative and vancomycin as a gram positive is the initial dose, and later on the revision of the antibiotics to be done once a culture comes. Is there anything you follow in this, your pediatrics?
Again, sir, we will keep it very simple based on the institutional policies, because if we look at our own data, we don't have much of resistance to penicillin yet. So something like ceftriaxone, which is a broad spectrum, can cover most of the bugs. And if child has documented urine output after passing, and if we are looking at some gram-negative septicemia as a possibility, that is severe UTI, or in a child with a known UTI or a complicated UTI, or any evidence for gram-negative septicemia, we add amikacin at a lower dose, that is 10 mg per kg. Otherwise, we go up to 15 milligram per kg because the facility to check trough levels and peak levels is not easy in India. So we start off at a lower dose, that is 10 mg per kg amikacin and a broad spectrum like ceftriaxone. We reserve piperacillin plus tazobactam as a second line drug.
Okay, so what is your experience of starting steroid in this refractory sepsis?
Yeah, again, along with vasoactive agents, where I said some slides were missed, steroids. So there is enough theory to say that, but when we look at the data, Cochrane database, there is no advantage of using steroids early. But if the child is resistant to catecholamines, that is even after starting adrenaline and noradrenaline, if child's blood pressure, you are struggling, if there is any evidence of adrenal insufficiency, there is no harm in giving steroid under the cover of antibiotic. Because the only fear in pediatrics is that it might flare up sepsis. But again, there is enough data to suggest in catecholamine resistant shock, give early steroid that can save. And if the child presents to us in ER with cytokine storm, don't hesitate, just give. But I want to deviate from this by talking about cytokine storm, because we need to add on other therapies like Plex and then CRRT and immunomodulators and all. But steroids can be given in a child with catecholamine resistant shock. Most importantly, if there are any metabolic abnormalities, don't miss those things like hypoglycemia, hypothermia, hypocalcemia. All those things need to be addressed.
And this question may be out of the box, sir. So the initial putting of this A line and C line, what is the site you are choosing it, and how frequently you use these lines?
So most of the time we don't, if we talk about this point of care ultrasound for lung, most of the time we do not worry too much in ER, but once the child comes to ICU, that is by then golden hour would have been over. That is when we look at. But to answer your question, yes, we look at right or left axillary region, predominantly right infra or inferior axillary region, we look at it. And then we do very sincerely to look at evidence of fluid overload. Yes, we do look at it. And you asked how frequently, right?
Yes.
So if there is any evidence of fluid overload, the first sign of fluid overload in pediatrics is not hepatomegaly. That is tachycardia is the first sign. So for example, if the child has presented, as in our scenario, with a heart rate of 148, after first fluid bolus, it has come down to 138. And after second fluid bolus, it has come down to 110. And you think that there is still scope for fluid and you give another bolus. From 110, it has gone up to 122, which is still less than what it was earlier. But a heart rate of more than 10 above the baseline which you have achieved, lowest level, that is 110 was the lowest you have achieved, and now it has gone to 122. We still consider it as a first sign of fluid overload. If we wait for basal creps and hepatomegaly to appear, by then we would have caused significant fluid overload. So if there is first evidence of fluid overload, that is tachycardia has appeared after fluid, we start looking for signs of fluid overload using ultrasound. And to be honest, more than the A lines or B lines or C lines, we look at IVC collapsibility. That is something which we can train all the registrars and residents easily, and they can pick up if there is a collapsibility or it is fully dilated. That is something which is easy to be assessed, sir.
So that was a wonderful discussion. We'll see any more questions are there. So there are no questions in the chat box, sir.
Actually, apologies, some slides were missing. I think I started doing old presentation. I added a few slides on vasoactive medications, steroids, metabolic abnormalities, ultrasound, looking at the splanchnic circulation, point of care ultrasound in ER. Those things were there, but somehow they were missed. Sorry.
More questions from the audience?
No more questions, sir. So I think sir has explained in detailed way so that no one has questions. No one has doubts as well.
Some things which I can share at the end of this presentation tomorrow with Dr. Kiran is our ready reconner. And I can show a picture of the pediatric which we use. And then the drug dosage book which I promised. I will share all of them with Dr. Kiran. And then he can share with the participants.
So that was a wonderful discussion, sir. So if there's no more. Yeah. So if there's no more questions, we will wind up the topic.
Yeah. Thank you. Thank you, everybody, for the opportunity.
Thank you.